I'm pleased to invite Dr. M A Shahmy to make the first presentation on the heart where the kidneys are broken.
Good morning to all of you, and thank you very much for the Ceylon College of Physicians for giving me this opportunity. So today I will be talking about mainly the heart diseases from a nephrological point of view. Uh, in the case of chronic kidney disease, where and how the heart diseases differ and how they develop and what are the causes for that. As you can see, uh, this is a renal biopsy, which is incidentally shaped as a heart, which probably affirms the close connection between the kidneys and the heart. If we take the epidemiology, the heart diseases are far more common in the population of chronic kidney disease. Some diseases are as common as almost twice. As we see here, congestive cardiac failure is around twice more or more than twice as common in chronic kidney disease population. I'd be going through briefly all these diseases in where and how they differ in a patient with advancing chronic kidney disease. To start with, the coronary heart disease is the one of the most common problem we see in the chronic kidney disease population. So much so is many consider it to be an equivalent for coronary heart disease. The CKD is considered an equivalent to the coronary heart disease. Uh, the reason for this being a lot of traditional common risk factors which are both common to the both populations. The patients who develop chronic kidney disease also have, and the patients who develop the coronary heart disease both have these risk factors in common most of the time. For example, hypertension, smoking, diabetes, dyslipidemia, and a lot more. But there are several risk factors that are non-traditional and that are almost unique to the CKD population. And one of them being the retention of uremic toxins, which worsens with the progression of CKD. And I will talk about them more in a while. And also anemia, which is multifactorial in the chronic kidney disease patient, causes coronary ischemia. And there are the metabolic changes which see in the CKD patient with elevated cytokines and the poor nutritional state, which augments the atherosclerosis. Also, in the abnormalities in the bone and mineral metabolism, which causes increased calcification of the vessels, which also adds to the atherosclerosis and coronary heart disease. As we see in this diagram, in a normal patient with coronary heart disease, the calcification is only seen in the atherosclerotic plaques. But in the patients with CKD, due to many reasons, the intramuscular calcification is seen, which causes reduced pliability of the vessels and also increased ischemia. And the causes, as we see, can be all of these listed. And there are several other unique pathophysiological mechanisms which are found in the CKD population. One being the carbamylation of the LDL molecules, which is the most profound factor in driving atherosclerosis in the patients who smoke. But if we see from a different point of view, smoking also causes a lot of unwanted chemicals in the blood, and uremia also causes the same. So it is as bad as smoking. The carbamylation of LDL is commonly seen in the uremia population and also in smokers. and several other chemicals which accumulate in the blood, for example, ADMA, and many others inhibit nitric oxide activity. So this causes ultimately leads to vasoconstriction and ischemia, and also increase in the calcium phosphate products, which will cause increased intravascular calcification and worsen, as I told before. In broad strokes, the management revolves around the modification of the risk factors, and statin use in the CKD population is in a bit of controversy, but it is advised if the patient, in pre-dialytic patients, to start on statins, as it is a very high risk state. Also in the post dialysis patients, if the patients are not not on statin, not to start newly, but if the patients are on statin, to leave it while the patients are being dialyzed. And we have to control the hypertension, and as well as starting on the aspirin use is there is not much of a the trials have these findings have been from the subgroup analysis, but the aspirin is also advised in patients if the patients have other risk factors like previous coronary heart disease or any other significant risk factors. If the calculated score is very high, then we can start on aspirin. But we have seen in the chronic kidney disease population, there is a poor prognosis with interventions like PCIs and intravascular interventions. The reason being probably because of the vascular calcifications and vascular changes that happen in the chronic kidney disease. In this diagram, in picture, we can see the significant vascular calcification, the calcification of the aortic arch and the aorta as showed by the arrows. The hypertension is very common in the CKD population. Almost more than 85% of the patients will develop hypertension in one time or the other in their CKD states. And the pathophysiology is, it is multiple. Hypertension can be a causative agent for the development of CKD, and also in the end stage, the patients develop sodium retention and fluid retention, which causes hypertension. And because of the patients with chronic kidney disease usually are in renin, aldosterone, and angiotensin aldosterone system is hyperactive in them. So that causes angiotensin mediated vasoconstriction and hypertension. Also, this the afferent arterioles, the sympathetic system usually, because of the uremic toxins and also the sympathetic drive which is trying to dilate the afferent arterioles to supply blood to the kidneys, there occurs a generalized sympathetic overdrive, which also causes high blood pressure. And as we also know that the CKD produces hyperparathyroidism, which increases the intracellular calcium levels in the smooth muscles, which causes it to go into a tonic state, which produces vasoconstriction and high blood pressure. And we usually give erythropoietin to control anemia in the CKD population. Erythropoietin reduces the carbon dioxide mediated vasodilatation, which causes increased blood pressure. And as we noted before, the arterial stiffness increases in CKD because of the calcification. Also, CKD population are known to have the nighttime dipping of blood pressure. Normally in the normal population would have around 15 millimeter mercury of reduction in the blood pressure early morning, but which is not seen in the CKD population, probably because of the uremic toxins and increased sympathetic overdrive. So the management of hypertension is not much different from the normal population with the lifestyle modifications like salt restriction, weight reduction. And antihypertensives can be are also as in normal population, but we will have to pay special concern to the hyperkalemia because ACE inhibitors and ARBs can cause hyperkalemia, and also the use of diuretics in very end stage renal failure patients might not be useful. It is advised that if the eGFR is less than 30, the thiazide diuretics alone would give a very minimal benefit. But at that time, if we start on a loop diuretic, then the thiazide diuretics can be helpful with that. And also, to not only give the doses of the blood pressure antihypertensive medication in the morning, so we can spread out, giving a night dose also, which would help in that non-dipping of the nighttime blood pressures. And as we know, the final if it becomes uncontrollable, we can always go into dialysis to control the fluid and pressure overload. As we see here in the CKD patient, the yellow line shows the blood pressure of a CKD patient. We see in the early mornings it almost stays the same, but in normal population there is a dipping. The congestive cardiac failure, the heart failure mostly in the CKD population is a diastolic dysfunction, but I would talk mostly about systolic dysfunction in these patients, because the pathophysiology of it is multiple, and it is helped by these features. One is, as I talked before, the ischemia, coronary heart disease is more prevalent in the CKD patient. And also because of the hypertension, there is a significant pressure overload, and because of the fluid retention, there is a significant volume overload. And also, most of the time we create fistulas to access blood for hemodialysis, which causes a high output circulation and which could cause high output cardiac failures. And also anemia will support in this high output situation. And there is myocardial fibrosis noted in the patients with CKD, which I will be discussing in a moment. And there is also an entity called hemodialysis-induced myocardial stunning, which is post-dialysis. We can see wall motion defects without any blocks in the coronary arteries. This is thought to be because of significant fluid shifts during the dialysis and the pressure difference. This is just to illustrate when we have this high output fistulas, the patient has a high volume circulating through the heart, which causes predisposes to a dilated heart. So the management is mainly, we have to manage the fluid overload. In early CKD, we can use diuretics. In late CKD, that is mostly dialysis. And the hypertension should be managed. We can use beta blockers because there is prognostic benefit. And also, we have to manage the coronary heart disease and the anemia. Because of this, with the development of this heart failure, patients are more prone to get any arrhythmias, which will even worsen the cardiac failure. So we have to manage that. I would like to talk a bit about this entity called uremic cardiomyopathy, which is actually a name, which is a term which is coined in the pre-dialytic era, where they found patients with severe uremia without dialysis developing cardiac dysfunction. But in fact, it is a multifactorial entity which develops due to all the things I have mentioned before. So the causes are being that all the risk causes for the heart failure is contributing to that. And also there are several factors which in the uremic population, mainly the hyperphosphatemia causes a phosphatotoxicity to the myocardium, which goes and changes the genetic makeup to a bone forming features. So the calcification and fibrosis intramuscularly increases in the heart. And the FGF23, fibroblast growth factor 23, is also does the same thing, but the problem is it increases in the blood early in the CKD, far before the phosphatemia picks up. And this molecule, this has been recently diagnosed, the alpha klotho, which is a soluble receptor for the FGF23, which reduces, mitigates the effect of FGF23. So we find that increases in FGF23 and reduction in alpha klotho levels, which causes cardiomyopathy. Also, this FGF23 is increased. This is a adverse effect of increasing phosphate levels in the blood. So as we see, the cardiomyopathy is a final common pathway of all those features, like the hypertension, the other features of left ventricular hypertrophy. All those with these uremic features finally cause the entity called uremic cardiomyopathy. I'd like to discuss a bit about the arrhythmias. Atrial fibrillation is the most common arrhythmia found in CKD, but ventricular arrhythmias are also very common. The causes for that being the cardiomyopathy, as I discussed above, which causes and also the ischemia and ischemic foci can cause arrhythmogenic foci. We know that electrolyte imbalances are commonly noted in the CKD population, mainly in the advanced CKD population. When they are getting dialyzed, there is wild variation of electrolytes, mainly potassium, which causes acts as an arrhythmogenic, which is arrhythmogenic. And also rapid fluid shift during dialysis causes increased sympathetic activity and tachycardia, and that can also cause arrhythmias. And some drugs, like mainly the ACE inhibitors, ARBs, which can cause elevated potassium levels, and sometimes digoxin, which easily becomes toxic in the population, in the CKD population, because of the potassium differences. And most of these patients, we send home, some of them, we send home with a catheter in situ, probably permanent catheters or temporary catheters for some time. They act as an nidus for the development of arrhythmias. And the management of arrhythmias, in ventricular arrhythmias mainly, are to optimize all those risk factors I mentioned above. And we can optimize the dialysis with the change of an increase of frequency and ultrafiltration. And also if it is not smooth and if the electrolyte imbalances are too much, we can even opt for peritoneal dialysis, which will give a smoother transition of electrolytes. For atrial fibrillation, anticoagulation is advised in EGF if the EGFR is more than 30. In the population where the warfarin, it can be used as in normal population, and the apixaban is noted to have the least risk profile for bleeding. As we see here, while dialysis, the potassium levels vary widely. Here we can see around 4 milli equivalents of potassium change during the 4 hours of dialysis. But we tend to think that the patients, end-stage renal failure patients, are more resistant to hyperkalemia, but they are. But they are not very resistant to variations in potassium. It is same as the normal population. So this is detrimental for them. And the valvular heart disease, there is a very high prevalence. As noted in this slide, the aortic valve calcification is around almost 1/4 to 1/2 of the patients in end-stage renal failure on dialysis has that, and mitral annular calcifications are also very common. The reasons being the mineral bone disorder in the CKD causing increased calcification. Also, infective endocarditis, which has many risk factors in the CKD population, as I will discuss in a moment, which will cause valvular heart disease. And the high output states, which causes increased shear stress, will cause increased calcification and valvular breakdown. And some diseases like polycystic kidney disease and all has a cardiac component like mitral valve prolapse. So we can see in this diagram, first shows an aortic valve and the second a mitral valve, both in CKD patient and has significant calcifications. Infective endocarditis is in fact one of the most common diseases we treat in our hospitals in the nephrology wards. It has a very high mortality, and the causes being that we are recurrently introducing bacteria into their systems by pricking for hemodialysis. And lot of patients we send home with an indwelling catheter, which the tip is most of the time in the heart. So it is a direct access to the bugs to the heart. And uremia predisposes to significant immunosuppression, and a lot of patients have also undergone a previous transplant and are also on immunosuppressive drugs. And as I mentioned above, the patients also have valvular heart diseases, which predispose to infective endocarditis. And we see a lot of MRSA, and worldwide it is the most common in the end-stage renal failure and advanced CKD patients. And we treat with the most common used antibiotics are vancomycin and gentamicin. In this picture, we can see a permanent catheter in situ when we discharge these patients. It is easy access to the bacterium to the heart. I would also touch on, before ending, about uremic pericarditis. It is thought to be due to the aggregation of uremic toxins, which causes increased expression of interleukins and tumor necrosis factor, which causes pericardial inflammation, which can cause pericarditis and pericardial effusion. Luckily, the hemodialysis relieves the symptoms in more than 75% of the patients. Before ending, I would just talk about the cardiorenal syndromes. It is not a different entity. It's not a different disease or an entity, and it is just a aggregation of symptoms. And what interests us today is cardiorenal syndrome type 3 and type 4, which is an abrupt in type 3, an acute renal failure causing an acute deterioration of cardiac function. That is usually that is pulmonary edema, and the causes are being, as I mentioned above, all the causes can be lead to this. And the type 4 is actually what I have mentioned above, that is chronic kidney disease predisposing to heart failure. All the causes I discussed above can be a cause for this. So I would like to end with the same picture I showed you before. The kidney biopsy looks like a heart. Thank you very much.
Thank you very much, Dr. Shahmy. I think we have some time for questions.
Just one question. Now, when you looked at what you presented, one of the common groups of drugs that came out are the ACE inhibitors and the ARBs. Now, they will have a detrimental effect on the kidney as well, especially when the renal failure is advanced. How do you manage it? Because you need to manage the cardiac problem as well as the renal problem. So, what's a practical way of doing
it? Yeah. It is usually ACE inhibitors in most of the causes that causes renal failure, like diabetes. We see most of the patients are because of diabetes. ACE inhibitors play an important role. And also in proteinuric kidney disease patients, ACE inhibitors causes significant reduction in proteinuria, and also it slows the progression of kidney disease. But the problem is in end-stage renal failure patients, when you sometimes we receive patients like they are in end stage, and we need to work up them quickly, and we don't have much time. So at that moment, if we start on ACE inhibitors, their GFR drops even further, and we run out to a place where we need to start on acute hemodialysis with an acute catheter, which is more detrimental for them. In that situation, weighing the risks and benefits, we tend not to start on ACE inhibitors in very end-stage renal failure patients in that kind of a situation. But most of the others, when we follow up from an earlier stage, we start on ACE inhibitors or ARBs, and also just after the patient has been started on hemodialysis, and we can prescribe them without any problem, monitoring the potassium levels.
Shahmy, now when you are speaking about the statins, there was some reluctance in starting statins to CKD patients. Why is that, and what guidelines do you refer to?
Yeah. With regards to the statins, yes, statins normally KDIGO guidelines suggest that the statins can be started in the pre-dialytic patients, and just after dialysis, it is advised to, if the patients are on statins, to leave the statin dose as such, but not to start newly, because if the patients are not on statin, in dialysis patients, not to start new doses of statin.
What is the reason behind that?
Because I'm not really sure.
Any other questions?
This is a question sent for the Zoom chat box. Is there any association with dialysis and cardiac function?
Yes, there is it depends on the one thing. It depends on the mode of dialysis. In patients who have significant cardiac involvement, we tend to start them. We advise to start them on peritoneal dialysis, because it is more cardiac friendly, and the fluid shifts and electrolyte shifts happen over a long period of time, and also it is the variation of the fluid and electrolyte balance is not much high. But when we start on dialysis, there can be, as I mentioned, there can be many reasons that go into affect the heart, cardiac functions. Mainly the patients before dialysis, they are fluid overloaded. Usually they are fluid overloaded and hypertensive, and hyperkalemic. And average potassium level goes around 7, even in centers where you provide 3 dialysis per week. And after dialysis, it all varies. And this variation over time causes significant cardiac involvement and cardiac failure.
Okay. I think we are up for time, but Dr. Shahmy, thank you very much for that excellent presentation. It was a great pleasure having you with us today. I have a small certificate of appreciation